Hello, everyone. Today we're going to be talking about topics on fundamentals of nursing. One of the basic topics that are so important that um, are found in NCLEX exam that pretty much all the students across the board have some difficulty with. Now, why do students usually have difficulties? It is very simple. It's fundamentals are the first topic areas that everybody discusses, in the nursing program. And as students evolve through the nursing program, the topics kind of get pushed back, and people start to think as advanced nurses, forgetting those basic fundamentals. So today we're going to be focusing on a couple of topics in nursing that come from the basis of fundamentals. And one of the biggest things that we find students having issue with is yourselves, who are seniors. You get to the point where you feel like you advance in your knowledge, and yet we tend to forget these basic fundamental things that are kind of in the whole core of nursing. And one of the biggest things that I find a lot of students having issues with is the topics of health and wellness. So now everybody's on mute, but I just want to go kind of one by one and kind of have you guys tell me um, what type of care do nurses provide? So when you're thinking about the nursing care, what type of care do we provide? Can anybody answer that question?
We're supposed to provide a holistic care, meaning we think about everything from A to Z, their culture, their background, their beliefs, their experiences. We try to find out, meet all the goals by trying to find out what they're willing to accept, what they want to do, what they know, what they don't know. So we kind of have to figure out individualized care for that patient in order for them to have the best experience.
Absolutely, that's absolutely correct, Rochelle. I like how you put that. And one of the main things that we always talk about, it's the mind, body, and spirit, right? Because we know that if the mind and the spirit are um, at, at war in a way, right? That means that the body will suffer. The best example I can give you is working in a NICU, the ICU for the prematurely born babies, and 50% of those babies will die. They will not survive the premature birth. And one of the biggest issues there is that um, the patient is not really the child, right? The child was born with whatever deformities there are, and they either going to survive or not going to survive. But the real patient becomes the family, usually the parents, whoever is, the closest to the child. So usually the mom and a grandma, and then, on the dad's side, dad and their parents. But either way, the real care that I am providing to this family is the emotional one as well as spiritual one, because a lot of them at the moment when they're losing their child, they're losing their faith as well, and they can cause the emotional distress, and as we all know, emotional distress can also cause physiological distress. Now, what is the hormone that's secreted when we have a physical distress?
Cortisol.
Cortisol. And remember, what's good about the cortisol, or why does initially cortisol released as part of the flight and fight response? Do you guys remember that?
You're talking about the sympathetic?
So sympathetic nervous system, right? But it's a part of the flight and fight response. But what's the job of the cortisol? What does the cortisol do to the body?
To alive and make decisions, good decisions.
Actually, no, that's epinephrine and non-epinephrine that gets you more mentally acute. Uh, um, but we're talking about the cortisol. Cortisol does one specific things. And Marie, if you're trying to talk, honey, you're on mute, so I can't hear you. I I hear
I'm
you
sorry.
waving. There you go.
And Cruz increase the blood sugar, give you more energy to
There
open
you
your
go.
eyes. See.
There you go. So increases the blood sugar, right? So one of the issues when it comes to that is that think of it as this, as cortisol is the stress hormone that will always increase the blood sugar. So if I have a patient who is diabetic, their diabetes while they're sick, and it doesn't matter if they're mentally sick or physically sick, right? The response of the body is the same. Body looks at it as a stress. You know how they say, the happiest day of a woman's life when she gets married. Well, I don't know about that, but let's go with that theory that that's the happiest day of her life, right? She's the most stressed then. Her cortisol is through the roof and her sugar is through the roof. Now, that's good for the energy if you're trying to run around, but it's bad if you're already diabetic. So the point being is that when I have, for example, a diabetic patient, I expect at the time when they're sick, they're gonna get increase in blood sugar just because their body is dealing with stress, and as such, it has increased the production of cortisol. Now, what are the other two side effects that cortisol have besides increasing
He give you hypocalcemia, calcium, infection also. Big one is the infection.
That's the biggest one. So it's not the infection, right? We actually very frequently give in medication form glucocorticoid or corticosteroids. Now, is everybody familiar with the family of glucocorticoid? Right? That's what cortisol is. It's a glucocorticoid, right? Why would I give somebody a steroid like a glucocorticoid? What's the number one reason why we give steroids?
Inflammation.
For inflammation, but more specifically, severe inflammation, like allergic reaction, right?
Yes.
So you will find in asthma, we use that a lot. People who are having like an acute severe asthma, we can actually give the Solumedrol IV, right, or IM, and or we will give the pill form of prednisone. But the idea is it's an immunosuppressor, right?
Yeah.
It suppresses the immunity, which is the unwanted effect. So even though its a good job is to increase the sugar, because at the time when the body's under stress and needs more sugar to function better, the diabetic patients become, if you will, more diabetic or in more critical state because their sugars are going to go up. And this is why you're going to see a treatment of like a sliding scale uh, insulin being given while the patient is hospitalized. Yet when they go home, they go back on the same medications they were at because while they're acutely sick, it's because the cortisol is up. Again, we would give a glucocorticoid or corticosteroids, which is what the cortisol is, for anybody who is has a transplant, right? Transplant is the number one reason to give glucocorticoids because we want the patient not to reject the
So,
transplant or the new organ, right? And the problem is when we are decreasing the inflammation, when we are decreasing the immune reaction, at the same time, we are also decreasing immunity, right? So, do you remember the word opportunistic or secondary infections?
yes.
Right? Can somebody tell me what those are? What are
Opportunistic infection, it's like when somebody already have the immune system low and then they can catch any like pneumonia, any normal cystic pneumonia, it's one of them. Candidiasis, albicans, it's one of them too.
exactly? And think of it this way. Most of the patients who have COVID now, right? They don't necessarily die with COVID. They die with those secondary pneumonias post-COVID, which COVID is a viral infection. Remember, the viral infection is good for like a 7 to 10 days, right? That it's lifespan. But most of the viral infections will go away within 14 days. It's those opportunistic or secondary infections who are waiting for an opportunity for immune system to be down or decreased. They come in and they cause the secondary infection, which is usually bacterial in nature, right? So what the problem is when I have somebody who is either overly happy or overly sad or flight and flight, is we have a cortisol response and the secondary infections come in, right? So again, it's all about the body, mind, and spirit because I have a patient who is physically fine and maybe has a history of, or has diabetes currently, right, type 1 or type 2, I expect the diabetes will get worse if they have emotional stress like death and dying or a wedding or any of the bigger major events in one's life. So going back to what Rochelle was saying was that yes, we have to deal with the body, mind, and spirit, right? And we're looking at the holistic care. But the holistic care, there's a specific type of care that nursing focuses on. Can anybody tell me what that type of care is?
Is the patient-centered care or
Always patient center, you're right. We are always focused on patient. Patient is number one, right? It's always the center of our care. But the type meaning is different kinds of care that I can provide as a nurse.
is it evidence?
So evidence-based practice is a practice that we use, right, based on evidence when we provide care. So that's always universal no matter what. And this is the doctors and scientists and everybody in healthcare does evidence-based practice. But what I'm talking about is a prevention. So the current type of care that provide is a preventative care. Do you remember those concepts for fundamentals?
Mm-hmm.
Yeah, I remember.
The biggest thing is that I am trying to prevent a problem. So there's three types of preventative care. Can somebody else tell me what are the samples of the primary care preventions? So primary preventative care.
Would it be teaching
So teaching
or like
specifically about what?
about the disease process, about getting vaccination, like stuff you can do prior to getting the disease, stuff to prevent it.
To prevent it, right? So teaching itself is not necessarily preventative in nature, unless it's to prevent the problem. So teaching about diet and exercise. And this is why I was saying I was asking you what, right? So teaching about the diet and exercise, absolutely, that is the primary prevention, meaning I'm preventing the disease. Even more importantly, absolutely, vaccinations are huge. Giving vaccines is the best way to prevent having a disease. Does that make sense? Right? So as
Yeah.
such, that causes a primary prevention. So I call those PPs. Primary preventions is anything that prevents the disease. Now we have secondary prevention. Can somebody give me an example of secondary prevention?
Like mammogram testing, early detection of the disease, like
Yes.
mammogram,
Yes, screening,
screening.
screening, like
Screening. Yes.
colonoscopy, screening. Right.
Screening, exactly. So yes, both of you ladies are right. So mammogram, blood pressure, doing the lab work for cholesterol and diabetes, those are secondary preventative measures. Now, why they're considered to be preventative is because I'm trying to catch the disease early, right? So if I randomly do vital signs and blood pressure checks on my patients every 6 months, or let's say every year when the patient comes for the physical, I am more likely to catch the patient in pre-hypertension state and then teach them about the salt and diet and exercise and hopefully keep them in pre-hypertension state for way longer than if they didn't know about it, they didn't know they were pre-hypertensive, they were continuing their lifestyle, and now they're more likely to get the disease. The same way, I think Marie said mammogram, right? The idea is if I can catch the woman's breast cancer at stage 1, that usually just requires a removal, and very rarely do we do any chemo and radiation with stage 1. You usually just surgically remove it and put the patient on tamoxifen, for example, right? To keep the estrogen levels down if this was an estrogen bearing type of a cancer. And so if I can catch it at stage 1, that's great, versus if I catch it at stage 3 or 4, where not just the morbidity, but mortality is more likely, right? Then, the treatment is going to be much more severe. Now we have to do chemo and we have to do radiation, and they have, 50-50 chance of survival. So if I catch it early, right? So all those screening, the point of screening is Let's catch the disease early so we can prevent a complication from the disease, right? If I catch a pre-diabetic and I'm keeping their hemoglobin A1C at 7.1 to 7.2, that's great. That means we're being very successful at it, right? Versus if I catch the patient when their hemoglobin A1C is a 9, and at that point they have kidney damage and they have retinopathy and nephropathy and neuropathy, the damage is already done to the tissue, right? So we try to catch it before they really have those signs and symptoms, because once when they do, that usually means the disease has taken its toll, right? Somebody saying something? I'm hearing some background noise. If you don't mind, I'm just going to mute again. You can unmute yourselves when I'm asking questions, just so for the background noise, because we're taping this for people who are not able to come in. Okay, so that's good, excellent. So everybody feels okay that the primary prevention is prevent the problem. Secondary prevention is screening, right? SS, so secondary for screening. We're screening for the problems to catch them early enough before they become a big problem. And then we also have tertiary prevention. Can somebody tell me what is a sample of a tertiary prevention? Remember, you're all on mute. You gotta unmute yourself. Can anybody give me an example of tertiary?
So it's like the person is already affected by the disease, but the goal is to prevent disability or limiting the complications.
You got it.
Like the when they go to rehabilitation.
Yes, Ms. Harlendi. Yes, exactly. So the tertiary is to prevent complications from the disease. So then we treat it basically. So that's how I remember it. PP, primary for prevention, SS, secondary for screening, and TT is tertiary, is a treatment. And again, we're treating to prevent disability or early mortality, or the comorbidity of the diseases. The idea is let's treat it before it becomes bad, and hopefully this patient will have semi-normal a life, depending on what diseases that we're trying to treat, but at least not have as many complications. So that's primary when you're thinking and the test questions, when you're focusing on your NCLEX question types questions, when you're focusing on your exams. As we talked about when we do the test taking strategies, right? I'm always going to follow ABCs. If it's not ABCs, because this is not an emergency situation, right? Then I'm going to follow Maslow hierarchy of needs. So remember, in a Maslow hierarchy of needs, what's the bottom of the Maslow's hierarchy of needs? What's the bottom part?
As the physiology, like food, shelter, oxygen.
Physiologic needs.
Yes. So home and shelter, right? And physiological needs, including the disease processes, right? But remember, the step 2 is safety, right? Except when it comes to nursing and when it comes to your test question, is how you're going to look at the question. You're always going to put the safety first, right? So I'm not going to go ahead and do a head-to-toe assessment on my patient if when they come in, the first thing that they tell me, they're going to kill themselves. Well, at that point, safety becomes first. If I have a patient who is immobile and is bedridden, but maybe is having seizures, right? I'm going to have to put him in a seizure precaution, pad the side railing, do things to take care of the safety first, and then continue with my assessment part. So that's where sometimes students make a mistake when it comes to the test questions. It's because you're focusing on physiological needs, right? On the disease processes, where really in the actuality, the question is about safety. So always make sure, like we said before, read your question more than once. And then if the safety is what's being asked of you, know that that will be the number one priority for nursing no matter what. So before I do anything else, I'm going to assure the safety of my patient, and then I'm going to continue doing other things, right? So for example, I got the order from the doctor to give my patient a medication of some sort, right? So if the test question says, what are you going to do next? Tell me, what would you do next? I got an order for medication, one-time dose, PRN, or just times one. What's the
First
first?
thing, check the patient. They check the patient allergic if they need allergic for any kind of medication.
Right? So once when I get the order, I'm going to verify that this is the safe dose first, right?
Yes.
This is the correct safe dose, that I got the right medicine. This is what the doctor wants. And again, it comes to safety. The same thing, Marie. Excellent. Allergy. Absolutely. I'm going to look at to see if my patient has allergy. Again, for purposes of safety, right? What's
Yes.
the so now I check the medicine and they don't have allergy. I checked and it's the right dose of medicine. So my next step is going to be what?
If it is the right patient or something?
Exactly. So I'm gonna go to give medication to my patient. But the first thing I do when I enter the room, number one is gonna be what?
Identify the patient?
Exactly. But if there is an answer that says hand washing, again, safety, I'm preventing infection, right? First thing I'm gonna do is wash my hand. Then what I'm gonna do is I'm gonna go and introduce myself. I'm gonna say, hi, my name is Katarina. I'll be your nurse today. Then I'm going to look at the patient's ID band to check that that is the right patient. Does it make sense? But all the other
Yes.
safety things that I have done, I done all the other 9 things before I went to the patient's room. So the right medication, the right dose, the right route, if it's going to be an injection, the right site. And again, all those things come down to safety. So I do want to make sure that when you're asked those test questions, when you're looking at those test questions, are you number one considering safety as the first thing, and the next thing is that if I'm doing something in order, what does it make sense? Well, of course, I'm not going to give the medicine until I check the ID, right? And so if that's one of the answers, for sure, that's going to be the big one. Introducing myself too. That's just that basic thing. When I walk into the patient's room, I'm not going to go grab the patient. I'm going to say, hi, my name is Katarina. I'm your nurse today. I'm here to give you the medication, right? And then I'm going to find out that this is the right patient and right medication and so on. So hopefully I knew what room I was going into, but to be quite honest, that doesn't always work. Like especially in the nursing homes when they're confused and disoriented, they're going to each other beds and in each other rooms. They forget, they walk around and wander. So you definitely have to know that first and last name and date of birth, right? So again, focus on safety. And then if the question is not Maslow hierarchy of needs, as in it's not ABC, it's not Maslow's, then it's usually a nursing process, right? So you got to be looking at things. What is it they're asking me, right? Is it asking me what step of the nursing process I am in? Or is the questions asking what is the next thing I'm going to do, right? So the first thing, the most important thing is to find out in the question what step I am in. So if I say the nurse has done the patient came in with the hip fracture, we're setting the patient up to have a surgery, right? You know that safety will be my first thought, that risk for fall is going to be the first thing for this patient, because if they try to climb out of bed or do anything, they're going to be hurting themselves. So that becomes my nursing diagnosis. If I tell you that I have gotten the nursing diagnosis risk for fall, I could ask you what step of the nursing process I'm in, or what am I going to do next? So what am I going to do next, guys, if I made the nursing diagnosis? Anybody? Hello?
Can you repeat the question? Sorry, because it was repeat the question for me.
Absolutely. So I have a patient who came in and they're having they came with a fracture, doesn't matter what. So let's say fracture hip. And you know, as a nurse, the first thing that you're going to do, obviously, is going to be full assessment. And then the primary diagnosis for this patient is going to be what?
Pain.
The what?
Is that pain?
No.
Is a fracture pain?
You said safety, so would it be risk for fall?
Yes, risk for fall. Even though it is a risk diagnosis, in this case, this is the primary diagnosis. Now, pain absolutely will be part of it, and I'm sure the patient will be in a great pain, and certainly pain will be part of it. But understand, safety trumps the pain. Safety comes before pain does, because nobody has died from pain. Okay, now it might be harder for me to treat it. It might take me longer to treat the pain if I don't focus on it first, but it doesn't matter. It's all about safety, because what good is a pain pill if the patient crawls out of the bed, hits the head, gets now a brain contusion or a hemorrhaging in the brain? What good is that pain pill? Well, now I have a bigger problem than I had before. Does it make sense? So anybody who has fallen is now in a much higher risk for fall because they already fallen, right? So the fact that they have fallen, that's definitely one of their diagnoses. But the risk for fall, it's even further. That's the biggest one. That's the one that should be like, oof, that's my number one priority. So get the patient in safe. Put the bed alarm on if you have to. Um, get it closer to the floor if you're expecting seizures, and making sure that the side rails are padded, right? All those things come first before I would go to give them the pain medication. Does that make sense?
Mm-hmm.
because
Yes.
because even though we always say ABCs, right, starts with airway, breathing, and then circulation, ABCs will include vital signs, right? But pain is not a vital sign, guys. I know we call it a fifth vital sign, but it's not. The idea is it's not. So as such, pain can wait. So always go with safety first. You will never go wrong that way. Assure my patient's safety, and then I'm going to do other things. And of course, like I said, then it's the nursing process. Um, so somebody said the diagnosis was risk for fall, right? So if the question is saying what is the priority diagnosis, that means I am in the second step of the nursing process, which is the diagnosing. But the question can also ask you, what are you going to do next? So tell me, what are you going to do next after you diagnose the patient?
Implementation.
No, how can you implement something without knowing what you're supposed to be implementing?
You just diagnose
The intervention.
yeah.
The what? What's the next step of the nursing process after
Is the
goal?
diagnostic
And
uh,
then what
intervention
no,
Not that.
planning,
Now
guys,
class
goals,
planning.
planning. So
planning.
see how easy it is to make that mistake? Once when I made the diagnosis, the next thing is the planning. The next thing is the
Planning.
goal. You're gonna set the goals, right? So what are you gonna do as a nurse? You're gonna help your patient set the goals. Because remember, patient sets the goals, right? We do it together with them, but we don't do it for them, but we do it together with them. So setting the goals is the next. And then what you're gonna do is gonna be interventions, figure out what the interventions are. So again, be very careful. Right now, I could have given you a question that all of you would have gotten it wrong because you were not thinking planning. So after diagnosing, we're planning, and planning means setting the goals, putting the things together, right? So when it comes to the patient care again, we're focused on those preventions, prevent the problem, follow your ABCs if this is an emergency and urgency, follow Maslow hierarchy of needs, but put the safety first, or follow the nursing process. So essentially, if the 99% of the questions are going to go in this order, except there's one area that we didn't talk about, and that is a culturally competent care. One of the biggest things when it comes to the culturally competent care, it's actually just that. If you see that term anywhere, be very aware that that's probably the answer. So if I'm giving a care that it's focused on a patient, that has to do with the patient's beliefs and values, that is all based on culture. So words like culturally cognate care or transcultural nursing are one of those big keywords in nursing that are used a lot in the nursing in the tests. So make sure that if this is, if the question is talking about, a disease process, it doesn't really matter what the story part of the question is, but if the actual question before the question mark, the stem of the question says, what is the type of the care that the nurse is providing, be very cognizant of the fact that if it says culturally cognate care, that you step yourself and say, whoa, whoa, whoa. Did we talk about the patient's beliefs? Did we talk about the patient's values? Because if the question talked about either of those, that's the answer. The answer is culturally cognate care, or like I said, transcultural nursing. Does that make sense to everybody? Yes,
Yes.
Mom? All right. So it's a big
Yes.
one too. Very good. Right. So let's go back to that evidence-based practice and critical thinking, right? So critical thinking, when I say that word critical thinking, what is the first thing that comes to mind? Anybody? What is critical thinking to you?
For me, critical thinking is taking everything that you learn from medical terminology, biology, micro, everything up to the point where so you can be able to come up with um, um, an idea or an understanding of what's going on. So you
And then,
have to have prior knowledge or prior skills in order for you to kind of like have to just to figure out what's happening.
exactly, to make the right decision, right? And so the
Yeah.
critical thinking is based on the fact that you don't have to necessarily know all the evidence-based practices, right? But it needs to be part of it always, that you must check your evidence to see if this is the current practice, if this is what we're doing now. Because what you were learning in school 2, 3 years ago might no longer be the evidence-based practice, because the evidence might have changed, the research might have changed, and based on that research, we change our beliefs. And a very simple thing I can tell you, like the COVID again, right? Since it's a big part of our lives and your future lives very soon here. At first, we treated it as a viral infection, right? And it was all about this is a virus and how the body responds to the virus. But what we've turned out to be is that just like the type 1 diabetes. Do you guys remember how somebody gets a type 1 diabetes? What happens to the child usually? Anybody?
Is pancreas is not produce any insulin at all, like or family history.
No. Type 1
Pancreas
diabetes,
is not
type 1
is a
diabetes has nothing to do with
idiopathic.
family. Hmm?
Is no, I say it's idiopathic disease. That means
Yes,
it's
it's
what?
idiopathic disease. Why? What happened to this child? You remember? So,
It's
first of
like
all,
the
uh-huh.
I said the pancreas is not produce any insulin at all.
But why? The child had a strep throat. Guys,
Oh,
99.9% of the time. Type 2 diabetes is generic, inherited. Like my mom had it. I'm also overweight like she is. I know I'm going to get a type 2 sooner versus later. The way I live and how much sugar I eat, I'll probably get it sooner than she did. So she got it,
yes.
type 2 diabetes, when she was 55. So I'm looking probably around 50. I should be start checking for the diabetes because I eat a lot of sugar and a lot of sweet things, right? But the type 1 has nothing to do with genetics, has nothing to do with anything. That this poor child, usually it's a child, although it can be up to ages 20, 21, what have happened was a complete immune response. So the child had a strep throat, and the child's body, right? So it's not idiopathic. Remember, idiopathic means we don't know what happened. We know this child had an infection that usually is a strep throat, and the body caused an autoimmune response that killed, literally killed the isle of Langerhans, where the beta cells who produce the insulin have been damaged. So it becomes an autoimmune response, as in the child's own immunity. It's killing its own body. It's looking as the insulin producing cells as a transplant or a foreign body, and it attacks it. And this is why immediately, pretty much, they have to have insulin injections. This lasts a very short amount of time, and all of a sudden, this perfect child became a diabetic child um, in matter of weeks. So my point is the same thing we learned about COVID, right? COVID is a virus, it's an infection, but the people who die, they don't necessarily die from COVID, it's the results of the COVID, because it causes a lot of inflammation. So these patients end up having inflamed lungs, and they get an opportunistic infection like a pneumonia, and their lungs literally fill up with fluid. And one of the biggest things is why we say the comorbidity. Does everybody know what that word means, comorbidity?
Mm-hmm.
Yes.
Well, tell me.
Comorbidity is it's a second it's a second disease that you have beside the primary.
Correct. But to be a comorbidity is that those two diseases together make each other worse, right? So, for example,
Yes.
in most of the diseases, if I have, for example, have a COPD and I get pneumonia, definitely comorbidity, and I'm more likely to end up dying from that pneumonia because I have a COPD. But if I didn't have a
Yes.
COPD, right, or if I was a younger person, I should not die from pneumonia. Pneumonia is not really that deadly. And most of the pneumonians are bacterial pneumonians. If they are, give me an antibiotic and I should be fine. But the COPD is a comorbidity to pneumonia, which will make it more likely to be deadly. But what we found out that with COVID-19, unlike anything else we have seen, as a virus causes so much inflammation that if the patient has any other chronic disease, specifically kidneys or lungs or liver, they're going to get worse because of this inflammation that's being caused. And so it's almost like the body's overreacting to the virus and causing the secondary issue. Does that make sense?
Yes.
Because these patients go to ventilators and they live, for a month. Well, by then the virus is gone. It's the other stuff that ends up killing them. So the idea to comorbidity is something that makes each other worse. That's the thing. It's two diseases that because if I have a fracture, but I also have COPD, that's really not a comorbidity with each other.
No.
Makes sense? But if I
Yeah.
had AFib, right? And I am prone towards throwing a blood clot, and now I have a hip fracture. Now I'm more likely to throw that blood clot because remember, the flat bones is where we make the blood cells. And so more likely to get the blood clot anytime you have a fractured bone, especially if it's some sort of a flat bone, then the incidence of bleeding, of the coagulation and blood clots is much higher. Does it make sense?
Yes.
Everybody
Yes.
feel good with that? Okay, good. All right. So when we're talking about critical thinking, the idea is that you, as nursing students right now, are learning all these things from books. But really, critical thinking is the best done when you have the book knowledge and you have the practice. Because the practice is really what makes the critical thinking come to tuition. As in, um, you're as a nursing student, as you go through the nursing program, you're evolving, you're learning more, you're learning how to connect the concepts that you would have never connected before. But through the practice, that's where you get the actual perfection of it. That's when you can truly say that you become a critical thinker. And I have to tell you, for me, it was probably like a year and a half, maybe even 2 years of working in medical surgical unit before all this stuff that I learned from the books became alive. And then I also learned from other fields of how to do the better for my patient. So if my patient has an issue with ADLs, first of all, can somebody tell me what ADLs are?
ADF is the daily activities.
So activities of daily living, right? ADL, right?
Yes.
Yes, activity. So give me an example of an ADL.
Dressing,
Woman,
moving, dressing,
woman,
bathing,
Mhm.
feeding,
um,
Right, exactly. So
able to go out to buy things that they need.
no, that's not part of the
No, no,
ADL.
if they're able to bathe themselves, dressing, feeding.
So dressing, feeding, and grooming, those are the ADLs, the basic
Yes.
things, right? So what, if my patient has issues with ADLs, who would I call for a consult to help my patient?
OT,
OT. So occupational therapy deals with ADLs. Now, there's another branch of ADLs and it's called IADLs. Now, can somebody give me an example of IADL? I can't hear anybody.
I don't know that one.
Ah,
instrumental aid.
IADLs are those things that allow the patient to be independent and home. So things like
Like
making phone calls and
okay.
making doctor's appointments, driving to the doctor's appointment, paying bills, making food, right?
Instrumental. Instrumental.
Instrumental activities of daily living. So if the patient has an issue with ADLs, they usually end up in a nursing home if they need a full care. However, if the patient has issues with the IADLs, who am I going to call for consult?
PT?
A social worker.
Social
OT.
worker. Social worker is the one that's going to get the home health aid to the house to help patient with cooking and shopping and or order meals on wheels or making sure that that they have home health aid. They have people there around them to help them out. Now, home health aides also can help with ADLs as well if the need is not a full need. If it's like they just need a little bit help to button the shirts and put them on and maybe to wash their back, but they can still get in and out of the bathtub. But if this is too big of a safety issue and they can't get in and out of the bathtub and they can't get out of the bed by themselves, this patient is going to end up in a nursing home. Either way, ADLs is occupational therapy, IADLs is social worker. And then social worker gets involved to help out to get the services the patient needs to stay at home, because our goal is always to stay at home. We don't want them in a nursing home if we can help it, because their life and their level of activity is much better at home and their quality of life. So when we're looking at what can I do for my patient, quality of life is really important to put above other things, but never again above safety. So safety again will always make it first. And if it's not a safety issue, would be quality of life. What can I do for my patient to help him, to assist him, to aid him to have a more complete and better life? Now, if my patient has an issue with activity, mobility, or range of motion. By the way, what is the range of motion regarding to what? What body system does range of motion work with?
And
Would
the
it be
extremities.
would it be the muscular system?
So skeletal-muscular system is activity and mobility. Specifically, yes, you're technically right. It's part of the skeletal-muscular system, but specifically, range of motion only has to do with the joints and nothing else. Does it make sense? So joints, that's what range of motion is. So tell me, which therapy will help with the range of motion?
Physical therapy. PT.
And actually both. So I want to make sure you understand that when occupational therapy works only with upper parts of the body,
Yeah.
they very frequently do range of motion of the upper extremities.
Extremities. Okay.
Right.
PT is lower.
But PT will focus more on the lower extremities.
PT is lower extremities.
So when it comes,
Pastor, I have
Mhm.
a quick question. Doesn't the OT help mainly like using instruments, like teaching them how to use like go use the fork again and stuff like that?
How to use what?
Like you like utensils, like
Yes. So
equipment, you know.
again, feeding, bathing, and grooming, ADLs. That's what the occupational therapy works with. And absolutely, like they work with them very closely on not just putting on the clothes, but range of motion of the shoulder. Can they put the blouse on? And do they have the dexterity of the fingers to close the buttons? Or do we need to look at something that does not use the buttons for the patient, right? And yes, utensils for cutting. If my patient has an issue with a grasp or with a grip of the hand, they can't grab the fork and they cannot grab the knife to cut. So that's something that physical therapy will work with. Also, bathing, like the patient has an issue getting in and out of the bathtub. Well, they're the ones that will help with putting in the safety side rails for the patient to grab on, including even changing the shower to the shower from the bathtub so they don't have to step over. Getting them like the shower chair, right? When they get into the shower, they're sitting down. That's all occupational therapy. This is what I'm saying. ADLs, you should be thinking occupational therapy, but occupational therapy also very much helps with the range of motion, specifically to the upper extremities, where the physical therapy is about strength, it's about muscles, and also range of motion. So physical therapy is strength of the muscles, strength of the bones, and the range of motion, again, mostly for the lower extremities. You know, can they walk? Can they move the hip? Can they lift the legs? Can they squat? Because remember, what type of exercise builds the bone? You remember that?
Weight bearing exercise.
Weight bearing and or resistance, right? So for example, a weight bearing, like doing squats, it's perfect for the hip bone, right? But how do I weight bear in my arms? Well, if I push against something, right, I'm giving it a resistance. So it's like the weight bearing, exactly. Those type of exercises are the best for bone versus isotonic and isometric exercises that they're for the building of the muscle. Does that make sense?
Yes.
Yes? All right. If my patient has a respiratory problem, who am I going to call?
Respiratory therapist.
Right, respiratory therapist. And if my patient has issue with swallowing,
Speech therapy.
speech therapy, right? And the speech therapy was going to do what kind of a study to get to see for how thick my patient's fluids need to be?
Following.
Swallow study, right? So based on the recommendation of the speech therapist on the swallow study is how thick the liquids are going to be and what type of the diet my patient is going to be on, right? MPO versus like a gel thickness.
Soft,
Different, yeah, exactly. Or they're going to have fluids at all, or maybe they just do the pureed diet where we already mechanically chewed up for them, and so on. That is all going to come from the speech therapist. Very good. And of course, if my patient has issues with speech, it's going to be speech therapy again. All right, very good. So now let's talk about the delegation. So now we're done with the with the, who you're going to call in what case. And then, of course, I'm sorry, one more thing before we move on to delegation is that communication. Remember, communication is big in nursing. And so remember the basic principles of communication. I never want to be in the intimate zone with my patient, right? Personal zone is fine. That's the generally that 1 to 3 feet away from your patient, right? So you're not in their space. You're about, I'm sorry, 3 to 5 feet away from them. Sitting on the patient bed is fine. It's not really recommended because then you get your uniform dirty, or you can potentially bring stuff on your uniform and cause those nosocomial infections. Does everybody know what nosocomial infection is?
Yes.
Tell me, what is
In
it?
hospital acquired.
An infection that you have from the hospital.
Yeah,
Acquired.
hospital acquired,
In
right?
hospital acquired, right?
Now, you understand now why. Patient came in, it doesn't matter where their disease was that they came in. Their body is under stress, which means they're producing more cortisol. The more cortisol produced, the more immunosuppressed they are, right? And especially if they have an infectious disease and they're immunosuppressed, right? Now there's just so much more prone to those secondary infections, and usually they're HAIs, or we also call them hospital-acquired infections or nosocomial infections. But that's the biggest thing. They're just so much more prone to catch that secondary infection, and we are usually the cause for it, right? So I really prefer to sit on a separate chair, not on a bed of the patient. But very importantly, I want to be at the same level of the patient, right? Because when I'm talking to my patient, if I stand above the patient, what's the problem with that?
You like
It's a
There
authority.
is no eye contact.
You have like authority on him or on her.
Exactly. It's more of a superior pose, right? Versus we're sitting together, we're looking eye to eye, we're on the same level. Because to build that trust with your patient is, yes, they already know you, the nurse, and you know more than they do when it comes to the health literacy. By the way, does everybody know that word, health literacy?
yes.
Yes? Okay. Tell me, when I talk to my patient, when I'm teaching them something, at what grade level am I talking to them at?
Fourth grade.
Third.
Oh, third. Oh.
Third grade or 9 years old. So you're talking to everybody like they're 9 years old or in a third grade. That is the level of health literacy that we assume all of our patients have. Now, if the patient tells me I'm a nurse, I'm a doctor, I'm a pharmacist, then I can speak a little bit more my own language, right? But the whole point of nursing is that we use simple terminology, allowing our patients to completely understand. And so when we talk to them, we assume they don't know anything, that we're talking to them like they're 9 years old or third grade, right? So the health literacy, you can have a most educated person, for example, a lawyer, but has no health literacy because they're not anything to do with healthcare. So even though they're an attorney and they maybe have a doctorate degree in law, they don't know anything about healthcare. I'm still talking to them like they're 9 years old. Sense? All right. But the idea is we're sitting in the same level, at the eye level, when we're communicating with each other, to make sure that we keep that open line of communication. Because if the patient thinks that you're being superior towards them, when you're hovering over them, you're standing over them, then yes, it's that mark of authority. They're less likely to tell you things than if you're sitting down and you're open. And then very importantly, what kind of questions do we ask the nurses? What type of a question?
Open and
Open-ended.
ending questions.
Always, exactly, always open-ended, right? We don't want those yes or no. Yes or no questions usually will stop us from exploring something. And then certainly remember, if you are expecting something is going on, but the patient is not willing to discuss, you might have to ask the same thing just a little bit differently. You kind of need to beat around the bush until you get them to tell you what they need to tell you. But open communication is very important. And so we also have 4 stages of nurse-patient relationship. Does anybody remember what's the stage 1 of a nursing-patient relationship?
Oh.
I
I think
remember
the
too.
interaction phase, you have the
Walking phase,
So
the termination
first,
phase. I
the
don't
first,
remember.
First, you have orientation.
Yeah,
yeah. So
orientation phase. Yeah.
that's the pre-interaction, right? Pre-interaction is that orientation where before I meet my patient, I'm going to orient to, my patients, anything that I can possibly find out from the medical history, if they have a chart, to talking to the doctors or even other things like other healthcare providers, right? To tell me about the patient. So the interaction stage is that orientation stage when I'm learning about my patient without actually interacting with them, right? And then I have the actual interactive stage. And when I'm doing the original orientation with the patient, that's that first meeting with the patient, that's the actual orientation. It's when I'm orienting to the patient to the expectations of the relationship. Like I will tell my patient, hi, my name is Katerina. I will be a nurse for next 4 weeks. I will be coming to visit you at your home every Thursday at 3 o'clock for the 4 weeks. After week 4, I will no longer be coming. Meaning that during the orientation phase of the relationship with my patient, I am disclaiming or describing the termination time. It is very important to establish at the orientation point with the patient when the termination is going to happen, because a lot of patients, remember, have specifically those with psychological problems. They end up thinking, oh, we're going to be buddies or friends afterwards. No, this is a working relationship. You're not supposed to be buddies or friends with them afterwards, right? So right off the bat, you need to set the rules. These are the rules of the relationship. Then you have that interaction phase when you're working with the patient, when you're getting them better, right? And then the last one is the termination, when you're telling them, this is it, this is our last meeting, you seem like that you understand everything. And what is the best way that I, as a nurse, can assure that the knowledge of everything I was teaching them has transpired? What's the best way?
Is to evaluate them.
And what is that term called? What would they actually do?
Demonstrate.
That's it, the key word, the best way. So yes, Marie, you're right. It's that you need to evaluate their knowledge.
Ellen is right.
No, I mean, Marie, the other
Ellen
Marie.
is right.
I'm sorry, what?
Ellen is right. Demonstrate. Ellen is right.
Well,
Yes.
how you gonna demonstrate is to by evaluation.
No. But
Yeah,
what I'm
the
saying is that
returning, the demonstration, the returning, what you say. I don't know.
yeah, so can I jump in for a second?
Back teaching.
But what I mean by this, Marie is right, is that you have to evaluate their knowledge. That's what you're doing. But Herlande is a little bit more right by saying by saying I can evaluate my patient. For example, the patient can tell me about what they learned, but if they showed me, if they give me the return demonstration is the absolute best way to evaluate, right? So Marie was right. She was right. I need to evaluate my patient's knowledge, but the best way is what Herlande said, return demonstration. They can demonstrate to me the understanding and the knowledge of what they need to be doing, then that's great, right? But sometimes they can, or maybe we're doing it like this, right? Verbal one would be fine too, but the best way, so if the question asks what's the best way, always know the best way will be the return demonstration. That means they can prove to you they have the knowledge versus just tell you they have the knowledge. Make sense?
Yes.
Excellent. Very good, very good. All right, so let's talk about delegation. It seems like a lot of you are having issues with delegation. So let me ask you this. As an RN, right, now you're already RNs, technically. I mean, not technically, but you are. You're there. You're gonna be the bosses. You're gonna be telling people what to do. You need to know who you can rely on to do what. So as an RN, what can you never, ever, ever, ever delegate?
What you can eat, whatever you can eat.
Evaluation.
Evaluation, whatever you can
Teaching.
eat. Evaluation,
Assessment.
assessment, teaching,
I
whatever you
like
can
that.
eat.
Whatever you can eat. I like it. Thank you, Marie. That's nice one. Whatever I can eat. There you go. So yes. Now tell me, why not evaluation? What is it about the evaluation that makes it in something you cannot delegate?
You need more teaching. You have to teach the patient. You have to evaluate to see what you have to do, and then you have to reassess. You assess and you reassess.
That's the thing. Because the first
Yeah.
step of evaluation is assessment, right? You got to reassess to see, did the patient meet the goals or not, right? So by doing that, so this is why, yes, eat is absolutely fine, Marie. We can stick with that. I love it. But basically, the principle is you cannot ever ask anybody else to assess your patient. And because the first step of this evaluation is assessment, of course, that goes with it. And then the original teaching, that's the prig one. So it's not all the teachings, but just the original teaching. So if I have an LPN on my team, my LPNs know, remember, everything my RNs know when it comes to the skills. So my LPN knows how to do an AccuCheck, knows how to draw insulin, knows how to give insulin appropriately, right? But the original teaching has to come from an RN, but there's no reason why I cannot delegate to my LPN return demonstration by the patient. Does it make sense?
Yes.
Because my LPN knows how to do it just fine. Probably even better than I do because I don't have time for that. Does it make sense? So very
Yes.
importantly is original teaching and delegation and assessment. So for example, I have a brand new patient coming in with anything. Who has to see the patient first?
The RN.
Right. Because this is what?
This is a new admission. You have to do the teaching. You have to do everything.
You have to do the assessment. At the beginning, the first thing is the assessment, right? So
At the-
always has to be a runner.
Same process.
So it doesn't matter what the patient comes in with. This is the point. Patient comes in, end of story. Doesn't matter what they're coming in, is has to be an RN because the RN has to assess. So let's say I assessed my patient and I found out that they have history of seizures. Can I delegate setting up the seizure precautions to anybody?
To who?
Seizure precautions. Remember, anybody with a history with seizures, right?
Yeah, you have to
Anybody.
initiate a seizure precaution.
You got it. Got to initiate the seizure precaution. Can I delegate that? Yeah.
Yeah,
Again,
because he's just gonna put the you have to prepare for the ambu bag, the suction machine, whatever gonna be in there. That's when you're not gonna teach anything. You're just gonna just prepare.
exactly. So can my LPN do that?
Yes.
Absolutely. Can my MOA do that? My medical assistant or unlicensed personnel?
Yes.
I don't know if they know about that.
That's the thing, right? So the biggest part of the seizure precautions, right? If we're talking just a precaution, there's no reason why my nursing assistant cannot get the padding for the side rails, right? There's no reason why my nursing assistant could not get a sign that says seizure precautions. Everybody knows if the patient is on a seizure precautions, the bed always has to be at the lowest level,
Yeah.
right? All the time. If this is somebody who has epilepsy, then we're discussing about putting that mattress on a floor and not even having the bed, right? And having the safety mattresses on each side. So that's something that my nursing assistant can do. But the suction and the suction equipment, that would absolutely be an LPN. And then if I get an order, for example, from a doctor, right? If I have somebody who does have epilepsy, what is usually the drug we would give for epilepsy?
Is that the diazepam?
Diazepam, right? So remember, epilepsy is usually treated when one of those drugs like Neurontin, right? And or gabapentin, right? The medications, they're anti-seizure medications. However, the patients who take those medications often don't have good lab levels of the medication, meaning they're not taking the enough of the medication. Now, usually, number one reason for that, by the way, is the fact that it makes them feel drugged. It makes them feel like, relaxed, but too relaxed. And so they don't want to feel like that. So a lot of times these patients skip the dose or two. And before you know it, their lab level of gabapentin is not where it needs to be. And if it's not where it needs to be, they're in much higher risk for seizure. And usually they came in, specifically epileptic patient, because they just had a seizure because their level is down. So I know until that gabapentin level gets to be therapeutic, this patient is in much higher risk for seizure, right? So as
Yes.
such, I gotta have diazepam on hand. I gotta have an IV in that if I have to shoot up this diazepam IV, that it's available. So most of the time, as an RN, I would get the order. I would talk to the doctor and say, hey, doctor, this patient just had a seizure. The lab levels are low. I'm afraid you're going to have a seizure. Can I have an order for diazepam? You can put it in a syringe and glue it somewhere in a patient's room. Number one place, we put it in next to the on the IV pump. We would just tape the syringe on the IV pump with already drawn dose of the diazepam, usually 0.2. But does it make sense?
Yes.
All right.
Yes.
So it's very important, right? Whom I can do with. How about blood transfusion? Can I delegate a blood
Two
transfusion?
RN. Two
No,
RN.
you can't never
You
delegate that.
cannot.
It doesn't have to be two RNs. It can be one RN and one LPN, guys. It just has to
Oh.
be one RN. Okay? So this is number
Oh,
one. The RN is the only way they can administer the blood. So LPN cannot administer the blood, but LPN can help me
But he
check.
can verify with you.
Exactly. You can verify. You can verify the patient's ID number from the blood bank. You can verify the blood is good. Because remember, you have to look at the blood bag, and there should be no bubbles inside. If there's bubbles, that means that that's been contaminated. It's usually it's a work of the
Lysis.
bacteria. Exactly. That there's no blood clots. Then also LPNs know the A, B, and O plus versus minus. So an LPN can also not just verify the number from the blood bank, but also verify, let's say this is a O positive blood and my patient is AB negative, my LPN is going to know, no, we cannot give this blood. Does that make sense?
Yeah.
So it's very important that you understand that LPNs can help me with looking at the blood, with double checking, but administration has to be an RN. Do you understand why?
There's certain the assessment is the RN had to do the assessment.
That you got it. That's exactly it. Because allergic reaction with the blood transfusions are at 50%, guys. That's a lot. And most of the big ones are going to happen the first 15 to 20 minutes, right? But they can happen up to 7 to 10 days after the blood has been administered. So during the administration of blood, the more blood is put in, and again, think of the blood as somebody else's blood as a foreign object. The body will treat the blood transfusion the same way it treats a transplant. It's going to say, wait a minute, you don't belong here. Let me attack you, right? So only an RN can not understand, but knows the signs and symptoms of a true allergic reaction, and more importantly, what to do if this is definite, if the case is a transfusion reaction. Does it make sense?
Yes.
Everybody good with that? All right. So that's why it has to be an RN. Now, what about vital signs? Who can do the vital signs?
Uh, but the LPN, but the RN supposed to do the vital, the first vitals.
Ah, for how long?
For the first 15 minutes, and in 30 minutes, about an hour, you have to do it at least.
Well, so this is again not a guessing game. It's for sure factual. It's really up to you and your comfort. If you have a good team and people you trust, sure, you can engage them earlier. But the rule says most of the patients will have an anaphylactic type of a shock reaction, the big one, the first 10 to 15 minutes of transfusion of the blood. After that, if they didn't have it by then, it's less likely they would. But remember, we got to do vital signs every 5 minutes times 4, then every 15 minutes times 4, then every 30 minutes times 4, right? So generally, even though Marie is right, the first hour I should be there. I just telling you that you know that because it will take at least 10, 15 minutes for the reaction, for enough blood to be in to cause the reaction. The rule says this: the pre-vital signs, the ones before, should be really taken by RN because we're assessing the baseline. So it's still part of the assessment. And at least the first 30 minutes, it should be an RN because again, we're assessing for the big reaction. Once when the patient's vital signs are stable, in my case, that would be when we go to every 15 minutes. The first 15, so 5, 5, 5, 5, that's 20, and then 15 later. So that's 35 minutes. I would take those. If the first 15 minutes later, so that's now 35 minutes into it, is still fine, then you can go ahead and delegate. And who can I delegate the vital signs to?
LPN.
LPN.
So the MOA too. Medical, unlicensed medical personnel both can do vital signs as long as the vital signs are taken for not an assessment purpose. That's the key. So if it's taken for the assessment, it has to be an RN all the way, all 2 hours or 3 hours or however long it takes for blood to come in, because it's a part of the assessment. But in a real world, as long as the patient is stable, I have a stable patient, then in a stable patient where it's not for the purposes of the assessment, both unlicensed personnel and an LPN can take. So again, be very careful when the question is asking you. Let's say the patient you're assessing a patient as a nurse and you find evaceration. What's the next step?
Evacuate. Oh, you have to put a saline, cover it with saline.
Right, because
Cover.
what's the problem when I have evaceration? What are the two major problems here? First of all, is this an emergency?
Yes, it is. The dryness of the organ and the infection. That's when you have to cover it with a wet.
Actually, Marie, not an infection, hypothermia. So number one is because the viscera being exposed for more than 30 minutes without moisture will start drying out, and yes, the organs will start going bad. So we gotta get them wet. They gotta be wet. So I'm gonna soak the normal saline. I'm gonna put in the visceral area all bunch of sterile gauze, pour the sterile saline. I need that gauze to be wet. And then the second thing is, on top of that, I'm gonna cover. I'm gonna put in blankets and towels, and I usually even put a pillow on top of it and have the patient put their hand and hold it like this. Because at this point, if the viscera is showing, that means the core temperature is exposed to room temperature, right? And what's the problem with that? Hypothermia. Within 30 minutes, the patient goes hypothermic and then they can die on you. So this is a medical emergency. So the soaking, the covering, who does that?
The RN.
RN, And so can LPN. LPN knows how to pack a
Yes, you
dressing,
can.
dressing, right?
Yeah.
But an RN has to be the one calling the surgeon, explaining what have happened to get an OR. Because this is now part of the assessment. I assessed as an RN that this was evaceration. I delegated to my LPN to pack the wound. I'm delegating to my nursing assistant to take the temperature. That's fine. My nursing assistant knows how to take the temperature. They can take the temperature, right? But I, as an RN, have to talk to the surgeon, explain what happened, and get to the emergency surgery. We got 30 minutes, guys. In 30 minutes, this patient better be in the OR. Otherwise, they are going to go hypothermic on you, and as viscera is exposed, potentially, damage to the organs. So does it make sense?
Yes.
Again, initial teaching and assessment. As long as the assessment is involved, got to stay with the RN. And pass the assessment, an LPN can do pretty much everything an RN can do, except the initial teaching. But return demonstration, very much an LPN. All the tasks, all the things that we can teach the patient, LPN can reinforce the teaching. Okay? All right. Nursing theories. Let's see if you understand this. Who in today's world, when we talk about the nursing and nursing theories, who is the first theorist that comes to mind?
Nightingale.
Okay, so Nightingale technically was not really a theorist. She was the first nurse. She was an epidemiologist, but she was not really a theorist. I mean, she got the nursing school going and all that stuff, good for her. But I'm talking about a theorist. More nowadays when
Is
say
it
it again?
Prato?
Who?
Prato?
No, no.
Prato?
Nursing. Plato was not a
It's
nurse.
like Doherty.
Ah, so big one is Dorothea Orem. Dorothea in Leiningen. Why? It's because the way they have their theories, and unlike, for example, we have Watson and Swatson that talk about caring, and then Sister Callista Roy, she was all about caring and making sure you take care of your patient. You always put your patient first. All those things do apply, right? So when we're talking about caring and taking care of your patient, caring is what we do as nurses. That's our job, essentially, right? Is to care for our patients. But those theories, even though theoretically going to lead my way of treating my patient with care and respect and dignity and love and all those concepts of good communication, right? All those things stay along the line of caring. The biggest two are the Dorothea Orem and Miss Langenhardt, because they are contemporaries of nursing, which is what today's nursing practice is. Now, why is this important, guys? This is not important to remember their names, but what their theories are. Because based on those theories is how I will provide a nursing care. So again, if it's not ABC, if it's not a nursing process, if it's not Maslow hierarchy of needs, it would be one of the theorists. And the biggest one, these two ladies that we just mentioned. And what did their theories essentially say? Does anybody know what's the heart of the theory when you're looking at the answer on a test question, when you're thinking about your patient? What is at the heart of those two theorists? Anybody know?
Not competency. No, not competency. It's patient. They're always talking about the patient.
Patients first, how you treat the patient, how you approach the patient,
So
and
Rochelle,
how you.
that's all Watson, Swatson, and Callista Roy. That's the care. That's the caring part. But I'm not talking about the caring. The other two are talking about the physical aspects of the care, meaning not the emotional of or how you approach them, but how would you treat them. And the idea is this, and this is what the Dorothea Orem says. Don't unable your patients. That was the key word.
Oh,
Yeah, sure.
Don't.
allow them to do as much as they can do and
Yes.
encourage them. Okay.
Yes, you got it. That's the big one. So every time, if I give you a question and the patient is able to do something, who's going to do it? Nurse or a patient?
Patient.
Every time. Because I do not want to enable my patient. I want to allow my patient to do as much as they possibly can for themselves. Because if I do it, it's going to get in a point where I'm going to enable them to be able to do it for themselves. And now they're going to need me to do stuff for them. So that's that quote unquote tough love. But it is really tough love. Let them do it. Let them do it. Don't do it for them. The best one I can tell you is, like, I have a patient in a nursing home. She has arthritis, bad arthritis in her shoulders. But I'm going to give her that brush and I'm going to say, Grandma, come on, brush your hair. And I'm going to watch her. And maybe she can brush everything in the front, but she can't reach the back. Only once when I see her, I will say, come on, try as much as you can, try as much as you can. And I will tell her, because remember, the range of motion, we stop when it's painful. And we stop when there is a resistance, right? So I'm going to tell her, I said, go, try until it hurts. And then she goes, oh, it hurts here. Then I'm going to say, okay, stop. Let me brush the back. Because if I start brushing her hair, she's going to get to the point where she's not going to ever be able to lift her arms like that anymore. Now she's going to only be able to lift it up to the mouth to eat.
Yep.
If I feed her and brush her teeth, she won't be able to do that either, right? Because the range of motion is all about use those joints. The more you use them, the better you're off. If you don't use it, you lose it. And that's essentially what these two ladies are all about. Is they're basically say to you, if the question asks anything to do, what's the best nurse is going to do? Best nurse is going to get the patient to do things for themselves as much as they can and only involve others if we have to. Does that make sense? Sounds
Yes.
reasonable, right? Okay.
Yes.
Very good, very good. And let me just see for today what else we're going to talk about. The last thing, the legal implications, right? The legal implications, remember, it's important to understand what we can and cannot do. So a Nurses Practice Act, remember that one? Tells us everything that we can and cannot do as nurses, and this is very big deal. So if I do something that's outside of the nursing practice, the patient can sue me for what?
For malpractice.
For malpractice, because I'm practicing outside of my scope of healthcare. Exactly. And so remember, we have the Good Samaritan law that covers everybody outside of the offices, outside of the healthcare facilities, right? So if somebody gets hurt on an expressway, then I can go ahead and stop and help them, and a Good Samaritan law is going to cover me for me helping them, even if I end up hurting them. Like, let's say I do a CPR and then I crash their lungs, like I crashed their ribs because I pushed too hard. Well, this lady is 80 years old and she has a lot of arthritis, and for CPR to work, right, I have to push, and it's not my fault that her ribs cracked. Does it make sense?
Yes. As long as you stay on the scope of practice.
Yes, as long as that's the key. Thank you, Marie. It's exactly the key. Because let's say I decide the patient is choking and I need to do tracheostomy. Can I do a tracheostomy on this patient?
No.
Hell no, because it's outside of the scope of my practice. So even though the patient would have died without the tracheostomy, I was never trained to put a tracheostomy in, outside of the scope of my practice, and yes, they can sue me for that. Does that make sense? So, but as long as you follow the rules of the CPR and I gave the CPR the right way, they can't sue me. Even if I crack those ribs or, stab their lungs and the heart with those ribs that cracked, they cannot sue me. That's the bottom line. So, remember the word tort? Torts?
Mm-hmm.
What is it? what is a tort, Marie? Not Marie Kersant, the other Marie that's falling asleep on me there in that chair. Marie, the chair is too comfortable for you. What is a tort, Marie?
Tort is like a illegal, an illegal action.
Exactly, right? So remember labeling versus slander. What's the difference?
Um,
One is writing. The
And
other
one
one is as you do it in
speaking,
your
right?
speak.
And this is on a professional level, right? This is important
Yes.
because so, for example, I'm your professor. We have a student-professor relationship, but that's a business relationship. So if I call a student stupid, that is slander because I'm in a position of power. I'm in a position to change the reputation of the student by saying that somebody's stupid. Now everybody else can start thinking of that student as stupid because I said it, and that would be the slander. That is not good. Versus if I wrote down, which is labeling, right? If I wrote down patient did something or student did something stupid. But another aspect of that is the people who are at the equal level. For example, between two of you students, let's say two Maries get in a verbal argument. What is that called? And they call each other's names. It's not slander.
oh, that's labeling.
No, labeling is writing. Labeling is
It's
writing.
like
It's an
Oh,
assault. That is
assault. Yes,
assault.
assault.
Exactly. And if you start hitting each other, that's a battery. Now, why is that
Battery.
important? Yeah, these are all torts, right? These are all torts. These are all bad things. Oh, Marie, for both of Marie's, we can get in trouble for all of that, right? But for assault and battery, you go to jail. And that's
Yes.
the difference. So slander and labeling, it's something that's, frowned upon, that you should not be doing. You can get in trouble with work, but I'm not going to get to jail. With assault and battery, you get to jail, and if you get to jail, you can actually get not to be able to practice nursing because they can remove your nursing license. That's a big one. The same way for malpractice, right? If you do something outside of the care, like if I put that tracheostomy in, they can sue me. Does it make sense?
Yes.
All right, good, good, good. Um, and those are the biggest ones. And then, of course, you need to know those ethical principles. Make sure that you review them too. When I say beneficence, what does that mean to you? Ethical principle of beneficence.
You don't do no harm to the patient.
What?
You don't do no harm to the patient. You did
Yes.
something.
Well, that's non-maleficence. See, this is why you need to know the terminology. So non-maleficence means do no harm. Beneficence means always do in the benefit of a patient. So kind of the same, but not really, right? Because remember, the other thing is that, like as a nurse, you are accountable, right? You're accountable for your actions, but you're responsible for your patient's well-being, right?
Yes.
Not the same, but it's very similar. So accountability and responsibility are the big, big, big things. All right, so just make sure you review them. You feel, have a general idea, because they like to give samples of those also as a test question of, do you understand the different principles? All right, so we're at our 1:30 mark. And since the vital signs is like a big topic that I would like to spend a decent amount of talking about, how about we refer that for the next week? And we'll do the vital signs. And let's see, the next week it will be same at 1 o'clock. It will be on Monday, the 31st, and we're going to do infection prevention, and then skin integrity and wound care, and then safety, mobility, activity, and exercise, and we'll do the vital signs as well. Does this sound like a plan?
Yes.
Great. Do you guys have any questions for me about anything we talked about today? I mean, I know it's good. Like most of you are pretty good about, but you were missing that little detail that I think will be able to help you in a big kind of a way. Just to now, it's more clear. I hope the understanding of the concepts to know. But again, safety, 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 guys. Safety is huge. You see safety, run with it. That's the answer. Okay, unless it's an emergency and we're looking at ABCs. Safety is the big one. All right, very good. Well, thank you, ladies. It's been my pleasure, and I will see you next Monday at 1 o'clock, and we'll continue our fundamentals.
Thank
Wait,
you.
one quick question. You're gonna post this? I wanna listen to it over again. Do you
Absolutely.
know when you're gonna have the
Um,
chance to
so
post it?
as soon as we are done, I have to upload the video, and then the video takes generally about between an hour or two to upload to the YouTube. As soon as it's done, the YouTube and uploaded, I will put it on, and I'll send a link. I have to send
Okay,
you the
cool.
link. So let's put
Okay.
it this way. How about this? By tomorrow, you'll have the link. Okay.
Yeah,
Okay.
yeah.
And I want to make sure is that everybody's in 240 and 260 pretty much that's here with me today.
Yes.
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 Just so I know where I'm posting my links. No problem. Will do.
Okay.
It
Okay.
will be on YouTube.
Thank
Thank
you.
Thank you,
you.
You're welcome,
Professor.
Thank
ladies.
you.
My
Thank you.
pleasure. Bye.
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 Bye.